Everyone, and welcome to another session of The Six Patterns. I'm Kevin Leslie.
I'm Max Smith.
And we're going to explore some cases in this venue. Today, we're going to look at a lung biopsy from a patient who's 68 years old.
Male patient.
A male patient, as it happens. So a wedge biopsy was done. Do we need to know anything more about this patient before we look at this biopsy, Max?
Probably not.
Probably not.
Older, male, surgical lung biopsy.
Right.
We can go ahead and make our observations.
Yeah, absolutely. So here we are at 2x. I think this looks, from low magnification, like a pink-dominated biopsy.
It's definitely a pink-dominated biopsy. No big inflammatory cell infiltrate, no big tumor, not a lot of cells. It has a lot of pink appearance from low power.
And some weird distortion, too, because, wedge biopsies tend to have a smooth surface.
Yeah, when you do cross-section. Like any lung, nice smooth surface.
This one looks lumpy to me.
It looks like a cirrhotic liver, actually.
It does look like a cirrhotic liver.
That has a lot of fibrosis.
So
interesting.
Distortion by pink material. We have to have fibrosis at the top of our list.
Exactly. So, I think we're in the fibrosis pattern.
Pattern 2.
Pattern 2. Just from our 2x evaluation.
Yep.
So now we have to look a little bit further and see what are the additional histologic features we can find here.
Right.
So I'm not going to go any further than this right now as far as zooming in, because I think we can see a lot about the distribution of the fibrosis here in this lobule.
Yeah, I agree. So I'm looking at the pink part. So if I squint my eyes at it, it looks to me like it's a rind of pink that makes a circle, like a donut shape.
Yes, the donuts of fibrosis.
Donuts of fibrosis. That should trigger something in our minds. And the center of this donut looks like it's got alveolar walls that are pretty thin and not very inflamed or scarred or fibrotic.
Pretty thin. They are like perfectly thin. That alveolar wall consists of a capillary and two basement membranes and two flattened pneumocytes.
Yeah. So it's a weird combination of what looks like completely normal alveolar walls right next to distortion and fibrosis that encircles the lobule. And in the fibrosis, what in the heck is that, Max?
These little bundles here?
Yeah.
I believe that is smooth muscle bundles. Smooth muscle metaplasia.
In scar tissue. That can't be a good thing. I don't know how you remake normal lung from that.
I don't think you can remake normal lung from that.
Yeah, so this is a serious condition. It's pattern 2, so it's not the most serious issue to grab your attention. Pattern 1 would be, that's why we put them in that order. Acute lung injury, pattern 1. Pattern 2, though, is often a lethal disease. So it is important.
Very true. So what about this transition here from this advanced fibrosis that we said has smooth muscle metaplasia, that we're not going to recover any normal lung function from this portion of the lobule. But what about this transition from where we see the fibrosis to these alveolar walls here?
I think it's critical. I think this is the leading edge of the injury in this particular disease. So we think of it kind of like a prairie grass fire, right? So you burn the field, the prairie, and the charred earth behind the edge of the leading edge of the fire is the scar. The leading edge of the fire is right there, and those look to me like fibroblast foci.
That's right. Immature fibroblastic tissue made out of a bunch of myofibroblasts, proliferating right at the edge of the advanced fibrosis and marching towards that beautiful green grass in the prairie.
In the normal lung, yeah. So this is the story of a disease called
usual interstitial pneumonia.
UIP.
Why do they call it usual interstitial pneumonia?
You know, the historical reasons for naming things are never good. And that should be the subject of one of our video casts.
Another talk.
But for the moment, we have established that we have heterogeneous patchwork fibrosis with parts of the lung in the biopsy being spared and normal. These are critical features.
Completely normal.
Completely normal. And fibroblast foci at the leading edge between scar and normal lung.
And the distribution of the fibrosis is peripheral in the lobule, paraseptal, subpleural.
Correct.
All of that adds up to the usual interstitial pneumonia pattern of pulmonary fibrosis, which is seen in the setting of the clinical syndrome.
Idiopathic pulmonary fibrosis, or IPF. This is an important diagnosis. You'd think fibrosis is fibrosis, who cares? But the difference in approach to the patient with a UIP pattern of fibrosis in IPF is different than the approach to the patient with chronic hypersensitivity and fibrosis. So it's important for us as pathologists to keep that in mind.
Absolutely.
Not all fibrosis is alike, certainly not to the clinician.
Exactly. And prognosis-wise, patients with UIP of IPF have a worse prognosis than patients with pancreatic cancer.
Yeah, think about that.
It's not a diagnosis to toss around.
Right.
So that sums up this session on
Beautifully
fibrosis.
done. I agree.